Welcome. Today we will talk about some questions from the system Gastroenterology. So let's start. Here is a case. 75-year-old male presents with 2-month history of dyspnea, weight loss, and generalized lethargy. Past medical history included a previous left-sided hemiparesis due to a stroke, for which he took aspirin and perindopril. On examination, there is residual left-sided hemiparesis together with pale and slight jaundiced appearance. Investigation shows hemoglobin 5.5, MCP 109, which is slightly raised, and hemoglobin is very low. White blood cell 2000, which is also low. Platelet count 45,000, which is very low. Urine analysis increased urobilinogen. So what is the next most appropriate investigation? So there is low RBC, low WBC, low platelet count. So one patient has history of jaundice with stroke. So we may now see the correct answer. I think it's bone marrow aspirate. Oh no, it's vitamin B12 concentration. Now see the explanation. In this situation, serum vitamin B12 estimation is the correct choice. With a pancytopenic picture, raised MCV, the most appropriate step is to check vitamin B12 and folate, because vitamin B12 deficiency is a cause of pancytopenia, and here MCV is raised. So it's the clue to think about vitamin B12 deficiency, that means megaloblastic anemia. The other choices are considered only after the basic essay. Hemolysis does not explain the low WCC, nor the thrombocytopenia. A hemoglobin only adds weight to a diagnosis of hemolysis. Hepatoglobulin and the RBC labeled scan would add greater sensitivity to the diagnosis of hemolysis. The mild jaundice is typical of megaloblastic anemia. So due to megaloblastic anemia, due to vitamin deficiency here, there was mild jaundice. Now, because of increased destruction or red blood cell precursor in the bone marrow, increased degradation of red blood cell in the bone marrow. So here is the main clue is raised MCV. That means it does a case of megaloblastic anemia due to vitamin B12 deficiency, and vitamin B12 deficiency leads to pancytopenia in some cases. Now second question. A male teacher, 31 years says, attends clinic with his parents, who tells you that he has memory problem. The only other symptom is intermittent diarrhea over the preceding 4 months. He has limited vertical eye movement and exhibits rhythmic simultaneous eye and mouth movement. Now, which pathogen is most likely to be cause of his symptoms? I think this may be Clostridium botulinum. Now see the answer. No, it's Tropeirima huifili. What's the explanation? This is a tough question. The solution here is that the patient has Whipple's disease due to intestinal infection with Troponema whippleri. Non-neurological manifestations of Whipple's are common and include chronic diarrhea, malabsorption with steatorrhea, associated abdominal distension and tenderness. Neurological manifestations include chronic progressive impairment of higher mental function in association with seizure, myoclonus ataxia, and oculomasticatory myarrhythmia found uniquely in Whipple's. The diagnosis is made by duodenal or jejunal biopsy and demonstrating the bacilli within the mucosa or PSA staining. Characteristically, there is accumulation of glycoprotein and fat-filled macrophage within the lamina propria. Botulism does not produce this clinical feature and its related dementia is possible, but abnormal facial movements would be unusual. CZ cross-spell Jacob disease could also produce this picture, although myoclonus is usually more of a feature and cognitive impairment is more generalized and acute. Salmonella enteritis usually causes only an acute diarrheal illness but may lead to bacteremia and chronic long-term carriage and excretion. So now go to the question again. Here main clue was intermittent diarrhea for 4 months. That means it's a case of Whipple's disease which mainly present with diarrhea. With this there is neurological problem which is memory problem, vertical eye movement problem, exhibit rhythmic simultaneous eye and mouth movement. So these all are go in favor of Troponema Whipple's disease because there is combination of diarrhea plus neurological manifestation. Now we can read about vitamin B12 deficiency, means megaloblastic anemia, and also Troponema whippleri, that means Whipple's disease. So let's read from Davidson Medicine textbook. So this is the textbook of medicine, which is Davidson's Principle and Practice of Medicine. Now we will read about Whipple's disease. This rare condition is characterized by infiltration of a small intestinal mucosa by foamy macrophages, which stain positive with periodic acid-ship reagent. The disease is a multi-system one and almost Any organ can be affected, sometimes long before gastrointestinal involvement becomes apparent. So is the clue. In this case, initially there was diarrhea, then there was neurological involvement. Then pathophysiology, reflux disease is caused by infection with gram-positive bacillus, which is Tropeirima Whipple, which becomes resident within macrophages in the bowel mucosa. Within macrophages in bowel mucosa. Villi are widened and flattened, containing densely packed macrophages in the lamina propria. Villi are widened and flattened, which obstruct lymphatic drainage and causes blood absorption. Now, clinical feature: Middle-aged Caucasian men are most frequently affected, and presentation depends on the pattern of organ involvement. Low-grade fever is common, and most patients have joint symptoms to some degree, often as the first manifestation. Occasionally, neurological manifestations may predominate, and CNS involvement is the most serious consequence. In our case, the patient has CNS involvement. Now, investigation. Diagnosis is made by characteristic features on a small bowel biopsy with characterization of the bacillus by polymerase chain reaction. So, small bowel biopsy. Then management is initially intravenous ceftriaxone followed by chlorotrimazole for at least 1 year. Ceftriaxone for 2 weeks, 2 grams daily for 2 weeks. Clinical feature of Whipple's disease: more than 70% is gastrointestinal. And here most common is weight loss. Diarrhea 70%, but weight loss 90%. Steatorrhea, protein losing enteropathy, ascites, hepatosplenomegaly. Musculoskeletal, seronegative large joint arthropathy, sacroiliitis. Cardiac involvement 10%, which is pericarditis, endocarditis, myocarditis, coronary arteritis. Neurological involvement 10 to 40%, which is apathy, fits, dementia. Our patient has dementia. Myoclonus meningitis, cranial nerve lesion. Pulmonary 10 to 20%. Chronic cough, pleurisy, primary infiltrate. Hematological manifestation 60%. Maybe anemia, lymphadenopathy. Other 40% is fever, pigmentation. And clinical relapse occurs in up to 1/3 of patients, often within CNS. In this case, the same therapy is repeated. That means ceftriaxone 2 grams for 2 weeks and trimoxazole for at least 1 year. May be repeated, or else treatment with doxycycline and hydroxychloroquine is necessary. Okay, Whipple's disease is over. Now let's read about vitamin B12 deficiency. again it's the textbook of medicine, which is deficiency, principle and practice of medicine. Vitamin B12 deficiency causes megaloblastic anemia. So our daily average diet contains 5 to 30 microgram of vitamin B12, mainly fish, meat, eggs and milk in excess of the 1 gram daily. One microgram daily. The clinical feature of megaloblastic anemia symptoms most common: malaise, then breathlessness, paresthesia, sour mouth, weight loss, impotence, poor memory, depression, personality change, hallucination, visual disturbance. So in research, all are about neurological. That means poor memory, depression, personality change, hallucination, visual disturbance. Here one is respiratory complaint, which is breathlessness. Another neurological complaint, which is paresthesia. Gastroenterological problems, sore mouth, manifestation. Endocrinological, which is importance, and also weight loss and malaise. And the signs are smooth tongue, angular kylosis, vitiligo, skin pigmentation, heart failure, pyrexia. So our patient has presented with weight loss and some other problem related to pancytopenia. Now it about megaloblastic anemia. Folate is an important substrate of and vitamin B12 cofactor for the generation of essential amino acid methionine from homocysteine. So for the formation of methionine there is needed homocysteine. And for this reason we need folate and vitamin B12. This reaction produces tetrafolate, which is converted to thymidine monophosphate or incorporation into DNA. Deficiency of either vitamin B12 or folate will therefore produce high plasma levels of homocysteine and impede DNA synthesis. So when homocysteine cannot be converted into methionine due to lack of vitamin B12 and folate, then homocysteine level will be raised in the blood and it will cause high homocysteine level. The end results in cells with arrested nuclear maturation but normal cytoplasmic development. Nuclear maturation will be arrested but cytoplasmic development will be okay. So it's called nucleocytoplasmic asynchrony. All proliferating cells will exhibit megaloblastosis, hence changes are evident in the buccal mucosa, tongue, small intestine, cervix, vagina and uterus because these are proliferating cells. The high proliferation rate of bone marrow results in striking changes in the hematopoietic system in megaloblastic anemia. Cells become arrested in development and die within the marrow. This ineffective erythropoiesis results in an expanded hypercellular marrow. The megaloblastic changes are most evident in the early nucleated red cell precursors, and hemolysis within the marrow results in a raised bilirubin and lactate dehydrogenase. But without the reticulocytosis is characteristic of other forms of hemolysis. The iron stores are usually raised due to hemolysis. The maturation red cells are large and oval and sometimes contain nuclear remnants. Characteristic appearance is that of giant metamyelocyte with a large sausage-shaped nucleus, which is found in megaloblastic anemia. Here is the important line, which is the mature neutrophils show hypersegmented of their nuclei. That means hypersegmented neutrophil is seen in megaloblastic anemia with cells having 6 or more nuclear loads. If severe pancytopenia may be present in the peripheral blood, our patient has presented with pancytopenia. Then vitamin B12 deficiency is associated with neurological disease up to 40% of cases. All the advanced neurological disease due to vitamin B12 deficiency is now uncommon in the development world. The main pathological involvement is focal demyelination affecting the spinal cord, peripheral nerve, and optic nerve and cerebrum. Spinal cord, peripheral nerve, optic nerve, and cerebrum. The most common manifestations are sensory, the peripheral paresthesia, and ataxia of gait. Our patient has ataxia of gait with the most common presentation. Now we have already read about vitamin B deficiency clinical feature. Now go to the next phase. Investigation of megaloblastic anemia. Hemoglobin reduced. MCP usually raised here it was 109. Erythrocyte count low. Blood in oval macrocytosis, poikilocytosis, and red cell fragmentation. Neutrophil hyperpigmentation. Reticulocyte will be low. Leukocyte count will be low or normal. Here it was low. Platelet count will be low or normal. Bone marrow, increased cellularity, megaloblastic changes in erythroid series, giant metamyelocyte, dysplastic megakaryocyte, increased iron store, pathological non-ring sideroblast. That is non-ring sideroblast. Serum ferritin will be elevated due to hemolysis. Plasma lactate due to the LDS will be elevated due to hemolysis. Open markedly. Now, neurological finding in vitamin B12 deficiency. Peripheral nerve will be involved and it will produce globe and stopping paresthesia. Also loss of ankle reflex. Then spinal cord, it will cause subacute combined degeneration of spinal cord due to posterior plus corticospinal tract involvement. In posterior column, it will cause diminished vibration sensation and proprioception. In corticospinal tract, it will cause upper motor neuron sign due to corticospinal contraction and diminished vibration sensation due to posterior column lesion. Now, due to involvement of cerebrum, there will be dementia and optic atrophy. There will be also autonomic neuropathy. Then here is a line to see blood levels of vitamin B12 provide a responsible indication tissue stores, and its diagnostic is a diagnostic of deficiency and remains the first line test for vitamin B12 deficiency. Additional test will be measurement of methylmalonic acid, holotranscobalamin, and plasma homocysteine level. Now, causes of vitamin B12 deficiency: dietary deficiency, gastric deficiency, pernicious anemia, loss of penetration causing intrinsic factor deficiency, more common in individuals with other autoimmune disease, means Hashimoto's hereditary Graves' disease, vitiligo, or Addison's disease, or a family history of pernicious anemia. Finding of anti-intrinsic factor antibody in the context of vitamin B12 deficiency is diagnostic of pernicious anemia without further investigation. That means finding of anti-intrinsic factor antibody. If anyone has vitamin B deficiency and then you find anti-intrinsic factor antibody, it will make a diagnosis of pernicious anemia without any further investigation. A ceiling test, measurement of absorption of radio-11 vitamin B12 after oral administration before and after replacement of intrinsic factor has fallen out favor with the availability of antibody test. Previously it was done, but nowadays it is not needed to done due to availability of antibody test. Small bowel pathology, it also causes vitamin B12 deficiency, as vitamin B12 is absorbed in ileum. Then okay, it's all about vitamin B12 deficiency from Davidson medicine. Thank you all.